All right. Hello, everyone. The first surgery I will be presenting today is a popliteal artery bypass performed by Dr. Caitlin Hicks. To orient us here, we're looking at the inside right leg of a patient who presented with an aneurysm of the popliteal artery. To bypass the aneurysm, the great saphenous vein was harvested for use as a graft. Figure 1 marks the incision, made from the inguinal crease to mid-calf, anterior to the sartorius muscle. The great saphenous vein was harvested from lower calf to mid-thigh. Branches were ligated and heparin was injected to prevent coagulation. The popliteal artery was exposed above and below the knee by dividing subcutaneous tissue. Other structures identified here include the adjacent popliteal vein and the saphenous nerve, which remains embedded in fascia. To prevent rupture, the popliteal artery was ligated proximal and distal to the aneurysm. A longitudinal arteriotomy was performed in the above-knee popliteal artery first. The graft was joined to the popliteal artery in end-to-side anastomosis with simple running sutures. Similarly, a longitudinal arteriotomy was performed in the below-knee popliteal artery. The great saphenous vein graft was packed to below the knee and joined to the popliteal artery in end-to-side anastomosis. The following series of figures is a diagrammatic depiction of coil embolization for the aneurysm treatment. First, a microcatheter was inserted into the popliteal artery to access the aneurysm. It deposited coils into the aneurysm sac, then was removed. Finally, its entry point was closed with a U-stitch. Figure 8 shows the completed anastomosis of the graft and popliteal artery, with coils retained in the aneurysm sac. I developed the below-knee arteriotomy and graft attachment sketches for my final illustration, shown here in journal format. Didactic color was used for the graft and popliteal artery to clearly identify them across figures. Thank you, and I now welcome any questions or comments. Yeah, Juan?
Of the conditions, this very common here, additional common that I'm taken on this way from officers and just
Yeah, thank you. Yeah, thank you. I appreciate those comments.
I want to compliment you too on your tone, sketching, tone quality, and line work. It's really has a nice sensitivity to it. I agree that didactic color makes this thing pop.
Thank you, Tim, and thanks for being a great advisor for this surgery. All right. Oh. One. Mm-hmm. Mm-hmm.
the suture simple.
Mm-hmm. Mm-hmm. Oh, sure. Mm-hmm. Yeah, that's a great comment. I'll definitely add that into my next round of edits. Mm-hmm.
Use with the white line.
Mm-hmm.
To follow the suture.
Mm-hmm. Ooh, yeah, I think that would definitely be great to add in. Thank you.
The concepts very carefully use of color, steers the work, and it shows that it's point of view and action, issue action, sometimes it's color that really is the idea of One little comment that I would make, I would encourage you to go back and look at the suture needles.
Mhm.
I think yours look a little bit hairy, a little bit wide.
Mhm.
Suture material.
Mhm.
So,
Mhm.
so,
Mhm. All right, that sounds great. Thank you for your feedback. Mhm. All right. Thank you for all your comments. Now I'll move on to my second procedure, which is a cholecystectomy performed by Dr. Joseph Sakran. The gallbladder is positioned on the underside of the liver and releases bile into the small intestine to help with digestion. Bile can harden into gallstones, causing discomfort, inflammation, and digestion issues. A cholecystectomy, or gallbladder removal, is commonly performed to treat gallstones. Now I will present surgical sketches for a robotic cholecystectomy. 4 8mm ports were placed across the abdomen, and a camera was inserted through a port in the right lower quadrant. The patient was placed in reverse Trendelenburg position with their right arm extended. Figure 2 shows the surgical view of the procedure. Our view here is in the abdomen facing the patient's right shoulder. The fundus of the gallbladder has been retracted to reveal the underside of the liver. Relevant anatomy is ghosted in, which includes the cystic duct and cystic artery. These structures are identified as the inferior pole of the gallbladder is cleared of connective tissue and later will be divided. A window was dissected medial to the cystic duct. The infundibulum was retracted anteromedially as dissection continued around the posterior aspect of the gallbladder. Figure 4 shows the critical view of safety, where the lower third of the gallbladder is mobilized and the surface of the liver can clearly be seen between the cystic duct and artery. This view ensures these structures are correctly identified before continuing the procedure. Next, 3 clips each were placed on the cystic duct and cystic artery. In Figure 6, the cystic duct and cystic artery were divided between the 2 most distal clips. To mobilize the gallbladder off the liver, remaining connective tissue was hooked and cauterized. Any bleeding of the cystic plate was controlled with hemostasis, which was the last step before the gallbladder was fully removed. Finally, the gallbladder was placed in an endocatch bag and removed through the umbilical port. I combined figures 4 and 6 for my final slide format illustration, which depicts the critical view of safety and the division of the cystic duct and artery. Thank you again, and I welcome any comments or questions.
Suggestion on dash lines, cystic artery and cystic duct.
Mhm.
I'm wondering if that dash line might be or at the very least, I think I would take the needle line from the cystic duct and make it less in line.
Mhm. Sure, almost angle it a little more so it's more obviously off.
I
Okay.
think that would be the first step. And maybe you could experiment with that.
Mhm. Mhm. Thank you.
It's funny that you mentioned that because I was thinking of that myself. One of the things I was going to comment on, now that I'm seeing this here, is with the dash line, maybe people will have different opinions about this, but you might consider making the dash lines rounded, like to go along the structure of the structure, just to make it a little clearer, what's being cut. Because it is only so much with the leader line.
Mhm.
I think it would make it a lot clearer, in terms of, the location and the structure that's it.
Mhm. Yeah. Yeah, that's great. Thank you both for your comments. I'll definitely try those out.
So. Because I see that the echo of the theater line back up,
Mhm.
which is somewhat closely to the incision lines.
Mhm.
And I would change the
Mhm. Sure.
structure,
Mm.
so the void.
Mhm.
I believe scissors come right side circle. This is it's got lost.
Mhm.
There's very little conference.
Mhm.
I think a little bit more emphasis that's there.
Mhm.
would really, now I'm still system up.
Mhm. Yeah, that's a really good point. Using instruments to direct the viewer's eye to the action is a really helpful tool, so I'll definitely incorporate that when I'm making edits to this piece. Tim, did you? Okay.
I can agree with what he said. I'm wondering if the form is said
Mhm.
well, whether deep color clips have been placed,
Mhm.
and draw our eye right to that.
Mhm.
So slightly darker, ramp up side, draw our eye.
Mhm. Yeah, that's really helpful feedback. Thank you. Yeah.
You had an incredible eye.
Thank
And
you.
the way you use it to illustrate or teach, it's fantastic. And the color of the gallbladder in the finger here are perfect. They're beautiful and they're accurate. Dr. Sampson described the gallbladder as robin's egg or something.
Mhm.
That's exactly the color it is. It's just right.
Thank you.
To the comments about the instrument that's coming from the right,
Mhm.
a lot of real estate. That's probably take
Mhm.
off of that.
Yeah, we could give more space to the handle. That'd be great. All right. If there are no more comments, I'd like to introduce the next presenter, who's my classmate, Tanya Burge.
All right. All right. Hello, everyone. I'll be presenting illustrations from 2 surgeries today, starting with an above-knee amputation performed by Dr. Ying-Wei Lum. The amputation was performed on a patient with a history of diabetic foot infections leading to toe amputations. The color shown on the leg depicts the level of visible infection. A tourniquet was applied before the fish mouth incision was made 1 palm breadth above the knee. The cross-section seen in number 2 depicts the relevant muscles and vessels that you will see depicted in the next series of the sketches. In 3A, we are looking at the inside of the left leg. After the incision is made, the skin, fat, and muscle of the anterior compartment is divided until the great saphenous vein is visualized medially. In 3B, the incision is retracted and the great saphenous vein is divided. In 4, deep dissection is continued through anterior compartment muscles until the femur is visualized. In steps 5A and 5B, tissue is elevated off of the femur proximally, then the femur is divided. After dividing the femur, the distal bone is lifted. This gives space for the amputation knife to divide the remaining posterior portion of the leg. The extremity is removed from the surgical field. And in 7A, the rough edges of the divided femur are rasped. The cut popliteal vessels are identified, clamped, then suture ligated as seen in both 7A and 7B. As a reminder, the previously applied tourniquet prevents active bleeding in the surgical field at this time. Next, the sciatic nerve is grasped, extended, divided, then allowed to retract proximally. This is to prevent future neuroma formation. Finally, a 2-layer skin closure is performed. The deep fascia layer is closed in simple interrupted sutures, and the skin is closed with a vertical mattress suture pattern. I decided to fully develop step 6 for my final render. Here's that illustration in journal format. Again, this step depicts the major surgical moment of the posterior portion of the leg being divided, with labels indicating important vasculature. I'm happy to take any questions at this time. Tim.
I'd like to congratulate you and make an overall comment, not meaning to embarrass you. I had you for more sketching, which is the beginning of the course. So students get comfortable going in and capturing not the surgical moments, but more about tissue reaction, getting comfortable in the surgery suite. And this is just the epitome of some of the timidity that you had going in, and this piece is just so successful. You learn a lot, and it shows. And the tissue, and congratulate you on your success.
Thank you, Tim. You were so helpful for that, so thank you.
Really nice. Kind of going along with what Tim said, even the sketches in this surgery, while I think they're strong, really recognize a lot of the subtle changes you make to your final piece. And remembering some of the discussion as a class and faculty about your sketches along the way. You introduce some real subtle use of cast shadows, overlap, some tissue tension in the back, just a lot of numerous small things that have added up to make this a very successful final piece. And I think well beyond what your sketches were sketching. So,
Yeah, thank you, David. All right, if there are no other questions for this piece, I will move on to the second surgery. The second surgery I will be presenting is a non-dismembered pyeloplasty performed by Dr. Heather DiCarlo and Dr. Chad Krieger. A pyeloplasty is performed to relieve a constriction or blockage at the area between the ureter and the renal pelvis, known as the ureteropelvic junction, or the UPJ for short. I created this educational piece for a lay public audience to understand the procedure better. This is a non-dismembered procedure, meaning the ureter was not fully detached from the renal pelvis for repair. Instead, an incision is made vertically, then sutured horizontally to widen the constriction. The patient was placed in a right lateral decubitus position, shown in 1A. Figure 1B depicts the relevant anatomy in port placements. A double J stent, seen in blue, is first inserted to stabilize the ureter, and afterwards, 3 8mm ports are placed. In the first surgical step, the peritoneum is opened along the white line of Toll. The colon is then reflected medially to access the retroperitoneal kidney and ureter. At this point, the ureter is identified distally, and in sketch 4, freed proximally, up to the renal pelvis. Care is taken not to injure the gonadal vein, which is traveling parallel to the ureter. The next series of sketches depict the non-dismembered pyeloplasty performed in VY fashion. The longitudinal incision is closed with a V-lock suture, as seen in 5B, and the results of the closure can be seen in 5C. In the final step of the procedure, the peritoneum is reapproximated. I decided to fully develop steps 4 and 5A through C in Photoshop. Step 4 depicts the freeing of the ureter, along with the simplified AP view of the constriction at the UPJ. Steps 5A through C depict the pyeloplasty reconstruction. The yellow A and B circles clarify which points of the incision are closed transversely. The double J stent remains in the ureter throughout the duration of this procedure and is removed after about 4 weeks. Thank you so much for your attention, and I welcome more questions and comments at this time.
Good job on it.
Thanks.
It's said it's phenomenal. Seeing it, in your first one on the right, yeah, this one is phenomenal. It's there. You look back at the fact that there's a lot of that space into the respiratory team whole, and I've really seen it from that degree. So congratulations on that. As far as the pyeloplasty itself, over 80,000 pyeloplasty with December. So it's just what you were there on the day. I've never seen that. It's that great. Carl and I really good chapter. So speak to that, but really good job on the project. And then on your first sketch, where you had the conditioning, I've never seen a representation of the stent. You only usually see a stent from the cystoscopic view. They're so just seeing that and how it's going to play with the patient.
Yay. Thank you so much for your help throughout the surgery, Dr. Krieger.
This is a phenomenal surgery. Great job with the illustration. On 5, you can see.
Yes.
Just have one suggestion on 5A, where you have your big cell stent, the curlicue is so close to the instrument there that is causing a tangent. I might just use a little bit of artistic license to either rotate the handle away or over it a little bit, just to create some space. It's sort of defeating the depth that you're trying to show, and causes a little bit of an optical illusion with the depth that you have. So I just try to black handle.
Yeah.
Yeah.
This guy. Okay. Thank you. Thank you, Jenny, for that suggestion.
We had a comment from our YouTube audience from Julia Murner and Mama of our program. She mentioned that she really loves love that you all showed the barbed suture so beautifully. To mention that the V-Lock is a brand name, so maybe institution specific. Is that correct?
I'm probably not. Sorry, that was terrible. You said, yeah, it is. Dr. Krieger said, yeah, it is. Yes. Thank you for your comment. Oh, hey, David.
When I talked about this, together on patient education, I was wondering, maybe with the surgeon, so the apex A and B, they're pulled together, and I'm sure during the suturing that you really don't see any indication of those the two apex as they
One of those.
But I'm wondering if if there would be a little subtle indication of those two corners that come together, just to reinforce what you've done so nicely with the Then I just wonder if it would be normal, I know there wouldn't be a gap left. It seems like some things.
It's very subtle. And even when we were trying to show the chief president that public case, they had never seen this done before. They were saying size here this way, and you're going to bring in what? So on robotic, roll it out, do it out. So the idea is that it's going to be watertight at the end of it, but yeah, there's liberty there.
To add those questions. Yes. Yeah. Thank you, David. Hi, Corey.
Why is it that these shape incision, why can't it just be a vertical incision?
So that's the technique Nicholas, it's used a lot for bladder neck reconstructions, and the idea of the ureter, you already have a space, you were to open it and close it, like stride. I worry that lead it to the, you make it prone to restriction down again. The idea is you're making this restriction area a nice long and wide funnel shape anastomosis by the time you bring it back together. And this is a technique most of the time is made for crossing the vessel. This is one that's very used because of the crossing vessel. There's just a very abrupt intrinsic adynamic segment. So in this patient, it would perfect.
Thank you, Corey and Dr. Kruger. Oh, repeat the question and the answer. Okay, so for the YouTube audience, the question was essentially about why there needs to be a V incision between the ureter at the level of the constriction at the UPJ. And essentially the answer was that actually, Dr. Krieger, can you explain it more? Essentially, it helps with
Narrow focus and direction. Shape.
gotcha.
Because this area is like all and that's part of it. It's got your amount.
Gotcha. So it's ultimately for the prevention of a recurring like UPJ obstruction, and it actually aids with the construction of a widened like funnel for the UPJ.
Present. Sure, cutting down the direction. Hey, you don't have to over.
Gotcha. Gotcha. Thank you, Dr. Krieger. Alrighty. If there are no other questions, and thank you for all of your comments, I will now give the floor to our final speaker, Monal Chang.
Thank you, Tanya. Okay. Good afternoon, everybody. My first surgery today is a perimembranous ventriculoseptal defect, or VSD repair in an infant. I was working with Daniel Gottlieb-Sand. So VSD is a very common congenital heart disease where there is a hole in the lower internal wall of the heart, causing unwanted shunting of blood between the left and right ventricles. Infants generally have larger thymus, which may get in the way during surgery. So after entering the chest cavity, the thymus will be partially removed. And after opening the pericardium, a cardiopulmonary bypass will be established, which is a technique that basically stops the heart from pumping during surgery. A tourniquet will then be inserted into the right atrium to allow easy manipulation of the flaccid atrial tissues. And then the right atrium will be cut open. In figures 3 and 4, it depicts the spatial relationship between the VSD within the ventricle and the tricuspid valve in both the anterior and posterolateral views. Figure 5 is a surgeon's view, offering a direct overhead view of the VSD through the tricuspid valve. Only part of the VSD marked in blue here was visible in this context. The anterior leaflet of the tricuspid valve was retracted during surgery. By changing the tension and direction of the retractor, the defect is revealed in sectors. Care was taken not to injure the septal leaflet during surgery, marked in yellow here, given its position anterior to the septal defect. A patch harvested from the patient's own pericardium was tied down in place to cover the defect using interrupted plegitic technique and double arms needles. Finally, a suture will be placed at the enteroseptal commissure to mitigate potential tricuspid leakage in the future, and the atrium was closed in layers. For this surgery, I rendered the cardiopulmonary bypass and the rest of the figures in journal format. This is a close-up of steps A and B before the patch was tied down, and a close-up of steps C and D after the patch was in place. For this project, I also created a patient education piece introducing another approach, the transcatheter VSD repair for selective patients. That is all for my first surgery. I'm now happy to take any comments or questions. David.
It's like, so much of what surgeries we see is based on manipulation of tissue. A lot of things that you commented on during your production, I think you incorporate. I do have one question about thickness of the control. Was it that thin? It seems extraordinarily. Did you observe it in this thing?
During surgery, so to repeat the question, was the atrium wall really as thin as I depicted it? So during surgery, it definitely seemed very thin and flaccid because imagine all the blood are sucked out of the heart as it is. So it is not like in a typical view we see where the atrium is inflated. So maybe that's why it makes it look so thin. And also the view I've chosen, all the tissues are kind of rolled up together, so you don't get a chance to see the thickness of the tissue a lot. That answers the question.
Yeah, I think part of my perception of the thickness, maybe it's not so much the thickness, but it's the volume of the tissue as well. And I see the tissue reaction, which I really like, but it's also adding involved. So, yeah, thank you for this.
Thank you, David. Okay, moving on to my second surgery. My second surgery is a dismembered open pyeloplasty performed by Dr. Mingxian Wang. So the infant suffered from severe hydronephrosis due to adhesion, obstruction, and a high insertion of the ureter. The patient was placed in a oblique supine position, and then an extraperitoneal flank incision, meaning the peritoneum was left intact, was made guided by the location of the 11th rib. After opening the Geroda's fascia, a vessel loop was used for easy manipulation of the ureter during surgery. The ureter was liberated from adhesion bands found throughout the perirenal space, potentially attributed to recurrent infections in this patient. In figure 5, a segment of the uretero-pelvic junction was removed, with incisions made on both the renal pelvis and the ureter. A diamond-shaped cut is made on the radial pelvis, marked in red, and a T-cut on the ureter side, which include an oblique transverse and a longitudinal cut. The ureter was then spatulated and reattached to the radial pelvis as shown in Figure 7. Figure 8 shows that there should be smaller mucosal bites taken on the ureter side to prevent future urethral obstruction from the sutures. Finally, in this slide, we see a comparison of the pre- and post-operative changes in the uretero-pelvic junction. For this surgery, I render figure 4 to 6 and figures 7 to 9. That is all for my surgical presentation today, and I'm happy to take any questions or comments.
So effectively presented as you're going through the steps of the nations and clothing, something that's adding another level to your short presentations.
Thank you, Juan.
Comment some of the artistic risks you took and how you grew as an artist in this piece. And I hope that you'll kind of carry what you learned from that process forward and go on to more beautiful art.
Thank you. Thank you for being my instructor, Tim, and David too.
We have a comment from on our YouTube audience from Courtney Brimble. Beautiful sketches. Something to consider is perhaps using a cooler toned background so the lovely warm tones you use can stand out more against the background. Overall, wonderful job.
Thank you, Courtney. That was a really good suggestion.
Various layers and kind of transverse pattern on this first side. This is not a piece. It's one of those few cases that I don't enjoy doing. Challenging from a spatial view, kind of coming to the side and behind it. Not typical robot, you can see everything. So you've got the robot like solid. That's what you did. So that. Then the second thing is hot scissors on the right are very dull. Small movements of your hand will change time.
Thank you, Dr. Grant. Dr. Greer was just commenting on how difficult this procedure is, considering how small the baby is, and also like the incision made, and a lot of layers we need to go into, and how we solve the visual by, for example, pulling out different layers, renal pelvis, to be able to show that a deep layer incision and stuff. And also he commented on the pot scissors, which is like an instrument usually see in this type of procedure. Yeah, how that it shows subtle little changes, like the twist of the angles in the images. Yes, Juan.
Just notice something that is really solid.
Thank you, Juan, for the question. So the question was regarding the little arrows, like twisting arrows here at the very bottom of the page. So that was actually a decision made to show that the incision is not made facing the surgeon. It's something we discussed with Dr. Ming-Hsian Wang, that usually to make it easier for the attachment to happen, the incision, especially longitudinal cut, would happen like facing the pelvic, renal pelvis, which is like in the deeper layer of the wound bed. Yeah, so we just want to address that we want to clearly show how the cut is made, but also at the same time tell audience it's not being made on the side or aspect facing directly facing the surgeons. And yes, that is a very good suggestion to change the color of the arrows to white. That might actually bring more attention to it. Thank you.
You're not actually twisting. Just showing it.
Yeah, we're just showing so the question was, we're not really twisting the ureter. So we're just showing like which aspect or side of the ureter cut is going to happen. Because if we do it like backwards, it would be kind of hard to be able to see where the cut happens, because it kind of would be obstructed by another layer of ureter.
In that case, I would not suggest putting white. I would suggest dashed lines along the curve or stop on the side. So that properly.
That is definitely an idea that we could try that on. Thank you, Wong. Thank you again for joining. Thank you again for joining. I will give it back.
Congratulations to all the students. I think success in this course is demonstrated by, as I mentioned at the beginning, accuracy, clarity, and effectiveness of the illustrations, and showing things that a photograph or a video camera can't capture. And you have all done a tremendous job doing that. I also want to thank the people who helped the students have success in the course, our faculty in the department, the surgeons, residents, and fellows who welcome the students into the operating rooms, the circulating nurses, the whole OR staff, people who reviewed the students' sketches, and further explain the procedures in the sketch stage. So this opportunity to have this kind of access for the students into the operating rooms makes this course one of the strongest courses in our program. I'm extremely pleased with the success of the students. I want to thank the physical audience, the online audience, and I invite people in the auditorium to come and talk to the illustrators in our reception, which will take place in the lobby. Thank you all for coming today.